So now we'll be talking about the familiar we are starting the biochemistry. So familiar dyslipidemia, we have the hyperchylomicronemia, that is the lipoprotein lipase or ApoC2 deficiency, increase blood level of chylomicron or TG or cholesterol. So we have the pancreatitis, hepatosplenomegaly, eruptive or pruritic xanthomas, no increased risk of atherosclerosis, creamy layer is super natant. Okay, we have the second is hypercholesteremia, is absent or defective LDL receptor or defective apoprotein B100. Okay, so there is heterozygous 1:1500 cholesterol 300 mg per day homozygous and have cholesterol greater than 700. Isolated atherosclerosis have MI before S20 and tendon RPS, xanthomas and corneal RPS. And we have dysbeta lipoproteinemia, that is ApoE defective in type 3 and chylomicronemia and BDRL. Mature atherosclerosis 2 eruptive and palmar xanthoma at the hand. Type 4 is hypertriglyceridemia, is hepatic overproduction of VLDL, TG, hypertriglyceride greater than 1000 and can cause acute pancreatitis related to insulin resistance. Next we have the orbital lipoproteinemia, that is autosomal recessive mutation in the gene that encodes the microscopic transfer protein MTP. Chylomicron, VLDL, LDL absent, deficiency of B48 and 100. Affected infants present with severe fat malabsorption, dysuria, failure to thrive. Lateral manifestation includes retinitis pigmentosa, spinal cerebral degeneration due to vitamin E deficiency, progressive ataxia, acanthocytosis, intestinal biopsy shows lipid-laden erythrocytes, treatment restriction of the long-chain fatty acids, and large dose of oral vitamin E. So lipoprotein, we have the chylomicrons derived directly from TG to the peripheral tissue, T liver, posterior to liver, infrapancreatic and recurrent, which are mostly depleted of the TG, secreted by intestinal epithelial cells. VLDL deliver hepatic TG to peripheral tissue secreted by the liver. Ideally, intermediate deliver TG and cholesterol to liver, forms of degradation of VLDL. LDL delivers hepatic cholesterol to peripheral tissue, formed by hepatic lipase modification of LDL in the liver and pancreatic peripheral tissue, then taken up by target cells by receptor mediated endocytosis. LDL is lethal. HDL is mediated reverse cholesterol transfer from peripheral tissue to the liver, acts as a repository for apoprotein C and E, which are needed for chylomicron and VLDL metabolism, secreted from both liver and intestine. Alcoholic HDL is healthy. So lipoprotein are composed of varying proportion of cholesterol, TG, phospholipids, LDL. So lipoproteins are cholesterol, TG, phospholipids, LDL and HDL carry the most cholesterol. Cholesterol is needed to maintain the cell membrane integrity, synthesis of the bile acid, steroid, and the vitamin D. So we have the various key enzymes in lipid transport. Okay, we have the cholesterol ester transport protein, that is mediated transfer of cholesterol ester to other lipoprotein particle. We have hepatic lipase, degrades TG remaining in IDL and chylomicron recombinant. Hormone sensitive lipase degraded by TG stored in adipocytes, promote gluconeogenesis by replacing glycerol. Lecithin cholesterol acetyltransferase catalyzes esterification of 2/3 of plasma cholesterol. Lipoprotein lipase degrades TG into circulating chylomicrons. Pancreatic lipase degrades dietary TG in the small intestine. PCK9 degrades LDL receptor, increase LDL, serum LDL, inhibition increase LDL receptor recycling and decrease serum LDL. So liver and intestine nascent as HDL is converted by ALCAT to mature HDL and CETP. There is cholesterol of steroid, transfer of cholesterol ester to VLDL, IDL and LDL. So apoprotein E is functional dominant uptake, everything except LDL. Okay, so it is present in all. Protein E is present in all except LDL, and protein A1 is found only on alpha lipoprotein HDL and activates ALCAT, so present only in HDL. C2 is lipoprotein lipase cofactor that catalyzes cleavage, is present in all except chylomicron dominant and LDL. And apoprotein B48, that is mediated chylomicron secreted into lymphatics, only a part of particle originating from the intestine, so it is present only in chylomicron and chylomicron dominant. And B100 match to LDL receptor only in a particle originating from the liver, that is VLDL, IDL and LDL. Okay, so next is the what we call metabolic function fuel, that is 1 carb gives 4 calorie, 1 per 7 calorie, 1 fat gives 9 calorie. At 2 seconds we have the stored ATP, then at the 10 seconds we have the what you call the creatinine, phosphocreatinine. Okay, and the 1 minute we have the anaerobics, and 2 hours we have the aerobic metabolism. Okay, So fasting and starvation, priors are supplies the sufficient glucose to the brain and nourishes the in fasting state after a meal, glycolysis and anaerobication, insulin stabilizes the storage of lipid, protein, and glycogen. We have the fasting between the meals, that is hepatic glycogenolysis, hepatic gluconeogenesis, adipose release of heparin, glucagon epinephrine stimulate the use of fuel reserve. So starvation days is 1 to 3, that is glucose, blood glucose level maintained by hepatic glycogenolysis, adipose release of heparin, muscles and liver with shifts fuels used from glucose to heparin, hepatic gluconeogenesis from peripheral tissue like lactate and lining, and from adipose tissue from glycerol and propanol CoA. From oat chain fatty acid, the only triglyceride component that contributes to gluconeogenesis. Glycogen reserves depleted after day 1, and RBC like mitochondria and therefore cannot use ketones. So starvation after day 3, adipose stored ketone bodies become the main source of energy of the brain. And after these depleted, vital proteins degrades, starts leading to organ failure, and the amount of excess stored determines survival time. Next we have the adipose tissue. Fasted and fatty states. So epinephrine and glucagon activates from ATP to CAMP and activates the protein kinase. It activates the homosaccharide lipase. Homosaccharide lipase now breaks down the FA and glycerol into the from the fat to blood. But when you talk about the insulin, at first the glucose enters the adipocytes with the help of insulin, and glucose provides the triglycerides, whereas the next is the lipoprotein lipase is also activated by insulin and it gives free fatty acids. So next we will be talking about ketone bodies formation. In the liver, fatty acids and amino acids are metabolized to acetoacetate and beta hydroxybutyrate to be used in the muscle and the brain. In prolonged fasting and diabetic ketoacidosis, oxaloacetate is depleted from the gluconeogenesis. With chronic alcoholic overuse, excessive NADH sends oxaloacetate to malate, and all of this process leads to build up acetyl-CoA, which is turned into ketone body synthesis. Ketone body acetane, acetoacetate, and beta hydroxybutyrate. Breath smells like acetone, protein unit test from ketone can detect acetoacetate but not beta hydroxybutyrate. RBC cannot utilize the ketone. The strict use glucose SMG-CoA liase for ketone body synthesis and sphingosine for cholesterol synthesis. Now we'll be talking about the fatty acid metabolism, that is from the citrate and from the mitochondria. Now we'll be talking about the synthesis. From mitochondrial matrix we have the citrate, and from the mitochondrial membrane citrate subtle. The citrate get passed away and it converts from the ATP citrate liase to acetyl-CoA, and from the acetyl-CoA it converts to malonyl-CoA with the help of acetyl-CoA carboxylase. Insulin potentiates this and glucagon absents it, and it is converted to malonyl-CoA, then it is converted to palmitate. It is fatty acid synthesis, 16 zinc carbon, okay, and then it is degraded, okay, and the fatty acid plus CoA is converted to now fatty acyl-CoA synthase to fatty acyl-CoA from the carnitine acyl transferase. Carnitine subtle fatty acyl-CoA is converted to acetyl-CoA, and from the this goes on to the beta oxidation, acetyl-CoA dehydrogenase, and acetyl-CoA is converted to ketone bodies and TCA. Okay. Fatty acid synthesis requires transport of citric from mitochondria to cytosol. Predominant occurs in the liver, lactating mammary gland, and adipose tissue. Long chain fatty acid degradation requires carnitine dependent transport in mitochondrial matrix. So systemic primary carnitine deficiency, no cellular uptake of carnitine, no transport of LCFA into mitochondria, and toxic accumulation of LCFA in cytosol cause weakness, hypotonia, and hypoketotic hypoglycemia, dilated cardiomyopathy. We have the medium chain acyl-CoA dehydrogenase deficiency that decreases the ability to break down fatty acid into acetyl-CoA, accumulation of fatty acyl carnitine in blood with hypoketotic hypoglycemia, cause vomiting, lethargy, seizure, coma, liver dysfunction, hypoammonia, can lead to sudden death in infants or child by avoiding fasting. Now next we have the liposomal storage disease, liposomal enzymes deficiency, accumulation of the abnormal metabolic products, increased TSH, Niemann-Pick, and some form of Gaucher's disease in Ascani's Lewis. Takasaki disease, this had the enzyme deficiency hexaminidase, and there is accumulation of GMP2 gangliosides. Okay, all are autosomal recessive except Fabry disease and the Hunter the Babylai Tarthugi, that is there both are X-linked recessive. So Takasaki disease is deficient is hexaminidase A, and accumulated substance is GM2 ganglioside. So Tay-Sachs disease, there is progressive neurodegenerative development delay, hyperreflexia, hyperacosis, cherry dot spot on macula, lipid accumulation in ganglionic cell layer, rhizome with onion skin, no hepatosplenomegaly. Versus Niemann-Pick, there is the deficient enzyme is the sphingomyelinase, and the accumulated is sphingomyelin. So pneumothorax disease is progressive neurodegenerative hepatosplenomegaly from cells, lipid-laden macrophages, cherry-red spot and macula. So next is the Gaucher's disease, most common hepatosplenomegaly, pancytopenia, osteoporosis, avascular necrosis of the femur bone crisis. Gaucher's disease, lipid-laden macrophage resembling crumbled tissue paper. So the enzyme deficient is glucocerebrosidase, beta-glucosidase treated with recombinant glucocerebroside, and accumulated substance is glucocerebroside. Okay, so next is the Fabry disease, that is the triad of episode peripheral neuropathy, angiokeratomas, and hyperhidrosis led progressive renal failure and cardiovascular disease. So deficient enzyme in Fabry disease is alpha galactosidase, and accumulated substance is cerebrosidase, trihexyminidase or globotriacyl ramide. Okay, metacrophic leukodystrophy, there is central peripheral demyelination with ataxia and demyelination. Accumulated deficient enzyme is arable sulfatase, and the accumulated substance is cerebroside sulfatate. And Fabry disease, there is peripheral neuropathy, destruction of oligodendrocytes, development and delay, optic atrophy, and globoid cells. Enzyme deficiency is the galactocerebroside. Okay, and the accumulated substance is galactocerebroside phycosin. Okay, so Gaucher's disease is glucocerebroside, whereas galactocerebroside is in the Krabbe. Okay, and galactoside is only deficient in Fabry. So Fabry, galacto, whereas Fabry and Krabbe, FK, FK, that is galacto and galactocerebro, and glucocerebro we know. Okay, so the next is glycogen storage disease. So at least 15 types have been identified, all results in abnormal glycogen metabolism and accumulation of glycogen within the cells. Past positive identified glycogen and is useful in identifying this disease. So we have 1 to 4 are autosomal recessive. Anderson, you have ABCD. Anderson is branching and Corey is debranching. As present card 8 monkey. So 1 Griffey is type 1. This is severe. So there is deficiency of glucose 6 phosphatase. Okay, so severe fasting hypoglycemia, increased glycogen in liver and kidney, increased blood lactate level, increased triglyceride, increased uric acid, gout, hepatomegaly. Liver does not regulate blood glucose level. Treatment is frequent oral glucose. Okay, avoid of fructose and galactose, impaired gluconeogenesis and glycogenolysis. Next we have the Cori disease, that is similar to von Grafe but milder form, normal lactate level. Okay, can lead to cardiomegaly, limit dextran-like structure accumulates in cytosol. So Cori disease we have debranching. Okay, so that is alpha 1,6 glucoside and now 4 alpha D transferase is a deficient enzyme, and gluconeogenesis is intact here. Okay, so Cori cycle, the intact thing is gluconeogenesis. So next we have the Pompe disease, that is cardiomegaly, hypotonia, exercise intolerance, and systemic finding leads to all death. We have the next is deficient enzyme here is lysosomal acid 1 alpha 1,4 glucoside acid maltase with alpha 1,6 glucocerebroside activity. Okay, next we have the Anderson. So Anderson disease is the type 4, is the branching enzyme, neuromuscular form can present at any age. So presentation is hypoglycemia occurs in late in the disease. Most common presence with hepatosplenomegaly, failure to thrive in early infancy. Other finding includes infantile cirrhosis, muscular weakness, hypotonia, cardiomyopathy, and early death. We have myocardial disease, increased glycogen in muscle, but muscle cannot break down its muscle, painful cramps, myoglobinuria, red urine with strenuous exercise, and arrhythmia from erectile abnormality. Second wind phenomenon noted during exercise due to increased muscular blood flow. So skeletal muscle glycogen phosphorylase, myophosphorylase is absent, characterized by a flat venous lactate cup with normal rise in ammonia level during exercise. So blood glucose levels typically unaffected. So next is we are having the glycogen. So branching have alpha 1,6 bond, lineage have alpha 1,6 bond. So skeletal muscle glycogen undergo glycogenesis, glucose 1 phosphate, glucose 6 phosphate, which is rapidly metabolized during exercise. Hepatocyte glycogen is stored under glycogenolysis to maintain blood glucose at the appropriate layer. Glycogen phosphorylase eliminate glucose 1 phosphate residue and off branching glycogen until 4 glucose until remains on the branch. Then 4 alpha D glucotransferase debranching enzyme moves 3 of the 4 glucose unit from the branch to the lineage. Then alpha 1,6 glucosidase debranching enzyme clips off the last remaining glucose. Limit dextran refers to the 2 or 4 residue remaining at the branch after glycogen phosphorylase has already shortened. So next is glycogen regulator of the insulin and glucagon and epinephrine. So the what you call the glucagon activates the glucagon receptor, okay, and it activates the adenyl cyclase. ATP is converted to AMP, and AMP activates the protein kinase A, and protein kinase A is activating the glycogen phosphorylase kinase, and this activates the glycogen phosphorylase, activates the conversion to glucose from the glycogen. Okay, so glucagon is increasing, the glycogen phosphorylase activate gas. Okay, so next is the insulin. Insulin is activating the glycogen synthase, okay, and directly, and the protein phosphatase, which is also indirectly increasing the glycogen synthesis. So epinephrine is doing what? Activating the endoplasmic reticulum in the liver, and epinephrine is activating the beta receptor in liver and muscles. So beta receptor in the liver and muscles activated by epinephrine activates the adenyl cyclase, whereas the epinephrine in the liver activates the alpha receptor that activates the endoplasmic reticulum and calcium, forming the calcium carbonate complex muscle in muscle contraction of the glycogen phosphorylase. So now we'll be talking about the organic acidemia. So that is most common present in infancy with poor feeding, vomiting, hypotonia, high on iron gap, metabolic acidosis, hepatosmegaly and seizure, organic acid accumulation, inhibits gluconeogenesis, decrease fasting blood glucose level, increase ketogenesis, increase high iron gap, metabolic acidosis, inhibit urea cycle and hyperammonemia. So propionic acidemia is deficiency of propionyl CoA carboxylase, increase propionyl CoA, decrease methyl CoA. So methyl CoA acidemia is deficiency of methyl CoA mutase or vitamin 12. So the treatment of both propionyl CoA acidemia and methyl CoA acidemia is treatment low protein diet limited to substance that applies into the propionyl CoA. So that is valine, oxygen fatty acid, methionine, isoleucine and threonine. Okay, next we have the cystinuria, that is hereditary defect on the renal, pituitary and intestinal amino acid transport that prevents the reabsorption of cysteine, ornithine, lysine and arginine cola. Cysteine is made up of two cysteine connected by the disulfide bond. Excess cysteine in the urine can lead to recurrent pituitary hexagonal cysteine stone. Treatment: urine and lysine and potassium citrate, acetazolamide, chelating agent like penicillamine. Increased solubility of cysteine stone, good hygiene, hydration and diet low in methionine. Autosomal recessive condition: cysteine detected with the urinary sodium cyanide nucleoperoxide test and proton nuclear magnetic resonance spectrometry of urine. Next we have the homocystinuria, that is the first, the homocysteine has to be converted to cysteine thione synthase with the help of B6 to cystathione, and from 6 to cysteine. From homocysteine it is converted to methionine, and from methionine synthase, and methyl folate plus B12 gives methyl B2. So homocystinuria cause all autosomal recessive cystathione synthase deficiency. Treatment: decrease methionine, increase cysteine, and increase B6, B12 and folate in diet. Decrease affinity of cystathione synthase for pyridoxal phosphate. Treatment: increase B6 and increase cysteine in diet. Methionine synthase, homocysteine methyl transferase deficiency. Treatment is increase methionine in diet. We have the methyl malonate tetrahydrofolate reductase deficiency. Treatment: increase folate in diet. Homocystinuria presentation: increase homocysteine in urine, osteoporosis. Homocystinuria in pneumonia is homocystinuria. So as for homocysteine in urine, O for osteoporosis, R for malformate habitus, O for ocular changes, downward and inward subluxation, cardiovascular effect like thrombosis, atherosclerosis, stroke, MI, kyphosis, intellectual disability, hyperpigmentation in skin. In homocystinuria, length subluxation down in pants out. So all captured causes reduction in homogenistic acid in the degradation pathway of tyrosine to fumarate. Pigmentation forming homocysteine acid builds up in the tissue. Autosomal recessive, usually benign, bluish black connective tissue near cartilage, sclera or chronosis. Urine turns black on prone exposure to air. May have deteriorating arthralgia. Homocysteine acid toxic to cartilage. Next we have the maple syrup urine disease. The blocked degradation of branch chain amino acid, isoleucine, leucine and valine due to decreased branch chain alpha keto acid dehydrogenase B1 cause alpha 1 increase alpha 1 keto acid in the blood, especially those of leucine. Treatment: restriction of the isoleucine, leucine, valine in diet and thiamine supplement. So maple syrup urine disease, we have autosomal recessive, present vomiting, poor feeding, urine smells like maple syrup burn and cause progressive neurological decline. Next we have the phenylketonuria caused by decreased phenylalanine hydroxylase or BS4 cofactor. Malignant PKO, tyrosine becomes essential. Increase phenylalanine, increase phenylketone in urine. Finding: intellectual disability, microcephaly, seizure, hyperpigmentation, skin eczema, mostly order, Treatment is decreased phenylalanine and increased tyrosine in diet, tetrahydrobiopterin supplementation. Maternal PQ is due to elevated maternal phenylalanine level can be prevented by dietary intake, finding includes infant microcephaly, intellectual disability, growth restriction, and congenital heart defect. So we have the phenylalanine, that is from the dietary protein aspartame and endogenous protein. Phenylalanine is converted to phenyl ketones, and phenylalanine is converted with phenylalanine hydroxylase to tyrosine. So the BS4 is converted to BS2, and BS2 is converted to BS4 by dihydropterin reductase, and malignant PKU occurs if there is absent. Then it is converted to tyrosine, and thyroxine, dopa, and melanin, and norepinephrine and epinephrine pathway is there. So phenylketonuria is caused by decrease in phenyl hydroxylase or tetrahydrogen BS4 cofactor malignant PKU. Tyrosine became essential, increased phenyl in urine, findings talk. Okay, so autosomal recessive incidence 1:10,000. Screening 2 to 3 days after birth. Normally at birth becomes a maternal enzyme, becomes fetal life. Phenylketone, phenylacetate, phenylactate, and phenylbutyrate. Disorder of erratic amino acid metabolism, must order PKU. Patient must avoid the artificial sweetener aspartate, which contain the phenylalanine. So when we talk about the amino acid derivatives, okay, we have the phenylalanine that is converted to tyrosine with BS4. Then from the tyrosine, thyroxine is formed, and again the BS4 is used, and the dopa is formed. Dopa forms the melanin, and the dopa, after using B6, forms the dopamine. Then from vitamin C to norepinephrine, and norepinephrine SAM to epinephrine. Tryptophan B2 B6 to niacin, and niacin forms the NAD plus NADP plus, and tryptophan using B4 and B6 serotonin and melatonin. Histidine using the B6 forms the histamine. Glycine using B6 porphyrin and hemine. Glutamate B6 GABA and glutathione. Arginine using the BS4 forms the nitric oxide, urea, and creatinine. Phenylalanine using the BS4 phenylalanine hydroxylase converted to tyrosine. Tyrosine can convert to homogenistic acid by oxidase to malonyl acid to acetic acid, that is from the alkaptonuria, and fumarate is there. So tyrosine is converted with the tyrosine hydroxylase to dopa, and dopa is converted to dopamine by dopa decarboxylase inhibited by carbidopa, and dopa is converted to melanin by tyrosinase using albinism. Dopa is converted to norepinephrine by using the vitamin C as dopamine beta hydroxylase. Norepinephrine is converted to epinephrine by using SAM, and also methyl ethanolamine and methyl transferase, and epinephrine is converted to methanephrine by category O methyl transferase. Methanephrine is converted to vinyl mandelic acid by monoamine oxidase, and the norepinephrine is also converted to normetanephrine by vinyl mandelic acid, and homomandelic acid is formed from the dopamine. Okay, so we have ornithine carboxylase deficiency, which is the So now we'll be talking about the ornithine carboxylase deficiency, the most common urea cycle disorder, acne recessive. Other urea cycle deficiencies, which are almost all deficiency interest with the body ability to eliminate ammonia, often immediate in first few days of life, but are present later. Excessive carbonyl phosphate is converted to uric acid, the part of the pyrimidine synthesis pathway. Increased uric acid in blood and urine, decreased burn, symptoms of hyperammonia, and no metabolic anemia versus uric acidemia. We have the urea cycle, that is amino acid catabolized generates common metabolite pyruvate acetyl, which is serves as a metabolic fuel. Excessive nitrogen is converted to urea and excreted by the kidney. So the carbon dioxide and ammonia water combines to form the CO3 minus plus N ammonia, and the carbonyl phosphate, that's allosteric activates N-acetyl glutamate, activates the carbonyl phosphate synthesis 1, converts into carbamyl phosphate. Carbamyl phosphate is converted with the ornithine transferase to citrulline. Citrulline with the aspartate added forms arginine-succinate. Arginine-succinate synthase convert forms the arginine-succinate. Arginine-succinate lyase forms the arginine and gives away the fumarate. And the arginine then forms the ornithine and with the arginase, and it forms urea and excreted into the kidney. So we have transported ammonia by alanine cycle. Acid and alpha ketone acid reacts to form the amino acid and alpha ketoglutarate forms the alpha ketone acids and glutamate further convert to alpha ketoglutarate acid through the same and forms the alanine. Alanine is from the muscles to the liver, and the alanine is converted to pyruvate. Okay, and forms the alpha ketoglutarate to glutamate ammonia, and the ammonia is converted to urea in the liver. Okay, and this conversion of alanine from muscles to liver is called Cahill cycle. Okay, and we have the Cori cycle, in which the pyruvate, which forms the glucose, is converted from the liver to the muscle, and from the muscle the pyruvate glucose forms. The glucose formed is converted to lactate, and lactate goes from muscle to liver. So hyperammonia can be acquired by liver disease or the hereditary urea cycle enzyme deficiency present with the phlebic tremor, hysteresis, slopping of space, somnolence, vomiting, cerebral edema, blurring of vision, increased ammonium changes, great amount of alpha ketoglutarate or glutamate or GABA glutamic acid to form the glutamate. CNS toxicity may involve decreased GABA, decreased glutamate, TCA cyclic inhibition, and cerebral edema due to the glutamate-induced osmotic shift treatment. Limited protein diet may be given to decrease ammonium level. Lactose to give acidified GI tract and trap ammonia for excretion. Antibiotic rifaximin and neomycin to decrease ammoniogenic bacteria. Benzoate phenyl acetate or phenyl butyrate reacts with the glycine or taurine, forming the product that are excreted renally. Okay. So next is the amino acids. The only L amino acids are found in the protein. So the essential amino acids: PVT, thymol, phenylalanine, valine, tryptophan, threonine, isoleucine, methionine, histidine, leucine, and lysine. We have the glucosonic amino acids like the methionine, histidine, valine. Glucosonic, ketogenic is isoleucine, phenylalanine, threonine, and tryptophan. Ketogenic is leucine and lysine. Acidic is aspartic acid and glutamate. Negatively charged at body pH. Basic is the arginine, histidine, and lysine. Arginine is the most basic. Histidine has no charge at the body pH. Arginine and histidine are required during the period of growth. Arginine and lysine increase in histidine with binds negatively charged DNA. Next, we have the lactose deficiency, insufficient lactose enzyme, dietary lactose intolerance. Lactase functions on the intestinal border to digest the lactose in milk and milk products in glucose and into glucose and galactose. Primarily age-dependent decline after childhood. Absence of the lactic present early, common in the people of Asia, Africa, or lactase amylation. Secondary loss of intestinal border due to gastrointestinal rotavirus or autoimmune disease. Yeah, and there is congenital lactase deficiency. Stool demonstrate decreased pH and breath shows increased hydrogen content with lactose from hydrogen breath test. As plus produced when colonies bacteria forming undigested lactose. Intestinal biopsy reveals normal mucosa in patient with hereditary lactose intolerance. Next we have the sorbitol. An alternative method of trapping glucose in a cell is to convert into alkalic counterpart sorbitol by aldose dehydrogenase, sometimes then converted sorbitol to fructose using sorbitol dehydrogenase tissue with insufficient amount of activity of the enzyme are at risk of intercellular sorbate accumulation causing osmotic damage like cataract, retinopathy, peripheral neuropathy with increased hypoglycemia and diabetes. High blood glucose level of glucose also results in conversion of osmotic active galactoside by aldose reductase. Liver, ovaries, seminal vesicles have both the enzymes. Glucose is converted to sorbitol by aldose reductase, and sorbitol is converted to fructose by sorbitol dehydrogenase. Lens has primary aldose reductase. Retina, kidney, and swan cells have only aldose reductase. Okay. So the next is disorder of fructose metabolism. Essential fructosemia involves the defect of fructokinase. Autosomal recessive of benign symptoms condition. Fructokinase deficiency is Skinner with since fructose is not trapped in a cell. Glucagon becomes a primary pathway for converting the fructose to fructose phosphate. Symptoms include fructose appears in blood in urine. Disorder of fructose metabolism causes milder symptoms than ongoing disorder of galactose metabolism. The hereditary fructose intolerance. The hereditary deficiency of autosomal B. Autosomal recessive fructose 1-phosphate accumulates, causing decrease in available phosphate, results in inhibition of glycogenolysis and gluconeogenesis. Symptoms present following symptoms of fruit juice or honey. Urine dipstick will be negative for glucose only. Reducing sugar can be detected in the urine. Not specific tests for inborn of carbohydrate metabolism. Symptoms cause hypoglycemia, jaundice, cirrhosis, and vomiting. Decreased intake of fructose or sucrose. Fructose for glucose and sorbitol metabolize. Fructose is converted to fructose 1-phosphate by fructokinase. Fructose 1-phosphate is converted by aldose to dihydroacetone, phosphate, and glyceraldehyde. Disorder of galactose metabolism. Hereditary deficiency of galactokinase. Galactose will accumulate in the galactose is present in diet. Relatively mild condition. Autosomal recessive symptoms. Galactose appears in blood, galactosemia, and urine. Galactose infantile cataract may present as failure to track objects or to develop the social response. Galactokinase deficiency is the kinder. Classical galactosemia, absence of galactose 1 phosphate urea transfer, autosomal recessive damage is caused by accumulation of toxic substance including galactose, which accumulates in the lens of the eye. Symptoms develop when infants begin feeding lactose present in their breast milk and routinely formulas include failure to thrive, jaundice, hepatitis, infantile cataract. Intellectual disability can predispose to E. coli sepsis in your breast. Treatment includes galactose and galactose plus glucose from diet. Okay. So fructose is aldose B and galactose is urea transfer. The more serious defect is to phosphate depletion. Okay. So galactose is converted by galactokinase to galactose 1 phosphate. Galactose 1 phosphate by urea transfer is galactose 1 glucose 1 phosphate. Okay. So next is the glucose 6 phosphate dehydrogenase. NADPH is necessary to keep the glutathione reduced, which in turn redistributes the free radicals and peroxidides. Decrease NADPH in the liver RBC to hemolytic anemia due to poor RBC defense against oxidative damage. Parabens, sulfonamides, nitrofurantoin, primacoin, chloroquine, antitubercular drugs. In fact, the most common cause can be severe hemolysis. Inflammatory response produces free radicals diffuse into the RBC, causing oxidative damage. Actually, recessive are most common human enzyme deficiency, more prevalent among descendant population in malaria, endemic regions, sub-Saharan Africa, South Asia. Hence, body denatured globin chain participated within the RBC oxidative stress. If the bite cells results from the phagocytic removal of the hen's bodies by splitting very fast. Glucose 6 phosphate is converted by glucose 6 phosphate dehydrogenase to 6 phosphate glucose and the glucose 6 phosphate dehydrogenase glucose 6 phosphate converted 6 phosphate glucose and then NADPH is formed. NADPH converts the glutathione reductase to oxidize glutathione reductase to glutathione oxidized to glutathione reductase, and glutathione reductase with the help of glutathione peroxidase converts H2O to water. Okay, so actually this X-speed deficiency is a metabolic disorder, most commonly human enzyme deficiency, more prevalent among descent of population in malaria, sub-Saharan Africa, and body denatured globin chain participated within the RBC due to oxidative stress by itself from the phagocytic removal of the hen's body by splitting macrophages. So next we have the pentose phosphate bundle, also called the SMP sum, provides a source of NADPH from abundantly available glucose 6 phosphate. NADPH is required for reductive reaction like glutathione reduction inside RBC, fatty acid and cholesterol synthesis. Additionally, this pathway requires ribose for ribonucleotide synthesis, two distinct pathways, oxidative and non-oxidative, both of which occurs in cytoplasm. No ATP is used or produced. Sites is lactating mammary gland, liver, adrenal cortex, and RBC. So in the oxidative irreversible stage, glucose 6 phosphate is converted to 6 phosphogluconate and ribose 5 phosphate, and glucose 6 phosphate is converted to fructose 6 phosphate. Okay, and glucose 6 phosphate is converted to 6 phosphogluconate by glucose 6 phosphate dehydrogenase. Glucose 6 phosphate dehydrogenase is converted to ribose 5 phosphate, and ribose 5 phosphate dehydrogenase is converted to ribose 5 phosphate, and ribose 5 phosphate is converted to fructose 6 phosphate by transcriptase B1. Okay, so next is the reactions are almost very important. So before starting this, I think I'll go with some of the enzyme terminologies. Now we'll be talking about the pentose phosphate partner, all called SMP cell, provide a source of NADPH and abundantly available G6 glucose 6 phosphate. NADPH is required for reduction reaction of glutathione reduction into the RBC, fatty acid and cholesterol synthesis. Additional, this pathway yields ribose for nucleotide synthesis, two distinct pathways, oxidative and non-oxidative, both of which occur in the cytoplasm. No ATP is used or produced. Site lactating mammary gland, liver, adrenal cortex, or fatty acids or steroid synthesis, and RBC. So next we have the gluconeogenesis, the irreversible enzymes, the pyruvate carboxylase in mitochondria, pyruvate 2 oxaloacetate, requires biotin ATP activated by acetyl-CoA, phosphoenol pyruvate carboxykinase in cytosol, oxaloacetate converted to phosphoenol pyruvate, requires GTP, fructose 1,6 bisphosphatase 1 in cytosol, fructose 1,6 bisphosphate converted to fructose 6 phosphate, cited positive EMP minus fructose 2,6 bisphosphate minus, glucose 6 phosphatase in ER, required glucose 6 phosphate to glucose. Next we have the occurs primarily glucose 6 phosphatase occurs primarily in the gluconeogenesis and reversible enzymes occurs primarily in the liver, serves to maintain the euglycemic during fasting. Enzymes also found in the kidney, intestine, epithelium. Deficiency of the key gluconogenic enzymes cause hypoglycemia. Most cannot participate in gluconeogenesis because it cannot because it lacks glucose 6-phosphate or chain fatty acids is propenyl CoA during metabolism, which can enter the TCA cycle as succinyl CoA undergo gluconeogenesis and serve as a glucose source to make glucose. Even chain fatty acid cannot produce a new glucose since they yield only acetyl CoA equivalent. So next we have the electron transport chain and oxidative phosphorylation. So NADPH electrons from glycolysis enters mitochondria by malate, aspartate or glycerol thick phosphate shuttle. FADH2 electrons are transferred to complex 2 at a lower energy level than NADH. The passage of the electron results in formation of a protein gradient that coupled to oxidative phosphorylation and drives the production of ATP. NADH सुरुमा बनेर कम्प्लेक्स 1 बाट NAD प्लस मा जान्छ. यसलाई अनि कम्प्लेक्स 1 लाई इन्हिबिट गर्ने रोटेनोन र मेटफर्मिन हो. 2,4 डाइनाइट्रोफिनोल एस्पिरिन ओभरडोजले चाहिँ कम्प्लेक्स विदाउटमा गएर जान्छ हैन. अनि FADH2 र FAD चाहिँ कम्प्लेक्स 2 हो, सक्सिनाइल डिहाइड्रोजिनेज भन्छ हैन. अनि त्यसपछि कम्प्लेक्स 3 भनेको चाहिँ इन्हिबिटेड बाइ एन्टिमाइसिन ए भन्ने हुन्छ. अनि कम्प्लेक्स 4 भनेको एजाइड, साइनाइड र CO ले इन्हिबिट गर्छ भने कम्प्लेक्स 5 जुन एटिपी सिन्थेज हुन्छ त्यसलाई ओलिगोमाइसिन इन्हिबिट गर्छ. सबभन्दा बाहिर भनेको माइटोकन्ड्रियल म्याट्रिक्स हुन्छ, इनर माइटोकन्ड्रियल मेम्ब्रेन हुन्छ र इन्टर मेम्ब्रेन स्पेस हुन्छ. ड्रागो भन्ने निमोनिक सम्झिनुपर्छ हैन. ड्राको. सो डी फर डाइनाइट्रोफिनोल, त्यसपछि आर बाट चाहिँ रोटेनोन, ए बाट एक्टिनोमाइसिन. ओके 3 भयो हैन अहिलेसम्म. अब 4 मा जाँदाखेरि ACCO. ACC चाहिँ हाम्रो ACC भनेको चाहिँ हाम्रो कम्प्लेक्स 4 हो अनि O भएर चाहिँ अग्लोमाइसिन हो. त्यसपछि 1 NADH gives 2.5 ATP whereas 1 FADH2 gives 1.5 ATP. So electron transport inhibitor directly inhibits the electron transport, causing a decreased protein gradient and blocks the ATP synthesis. Rotenone complex 1 inhibitor, actinomycin A, complex 3 inhibitor cyanide, carbon monoxide, azide, 4 later inhibits complex 4. Okay. So next is ATP synthase inhibitor, directly inhibit the mitochondrial ATP synthase, causing increased protein gradient. No ATP is produced because of electron transport stop. Next we have the uncoupling agent, increased permeability of the membrane, causing decreased protein gradient and increased O2 consumption. ATP synthesis stops but the electron transport continues, producing heat. 2,4-dinitrophenol used illicitly for weight loss. Aspirin fever often occurs after overdose, and thermogenic in brown fat has more mitochondria than white fat. So next we have is the TCA cycle, also known as the Krebs cycle. Pyruvate is converted to acetyl CoA, produce 1 NADH and 1 CO2. The TCA cycle produces 3 NADH, 1 FADH2 and 2 CO2. 1 GTP per acetyl CoA equals to 10 ATP per acetyl CoA, 2 into everything per glucose. TCA cycle details reaction occurs in the mitochondria, and alpha ketoglutarate dehydrogenase complex requires the same cofactor as the pyruvate dehydrogenase complex, vitamin B1, B2, B3, B5 and lipoic acid. So first pyruvate is converted with the PDH to acetyl CoA. Okay, here negative pyruvate dehydrogenase inhibited by ATP, acetyl CoA and NADH. Now acetyl CoA is oxaloacetate with the citrate synthase goes to form the citrate, then cis isonicate, citrate forms the isocitrate. Okay, isocitrate बाट चाहिँ isocitrate dehydrogenase भएर alpha ketoglutarate भन्छ. यो एन्जाइमलाई इन्हिबिट गर्ने ATP र NADH हो र पोजिटिभ गर्ने चाहिँ ADP हो. alpha ketoglutarate बाट चाहिँ NADH एउटा बन्छ हैन, जुन चाहिँ नियासिनको कम्पोनेन्ट हो. अनि alpha keto dehydrogenase चाहिँ बाट चाहिँ सक्सिनाइल CoA भन्छ. सक्सिनाइल CoA NADH र ATP ले यसलाई इन्हिबिट गर्दा हुन्छ. एन्जाइम सबै आर इरिभर्सिबल. सक्सिनाइल CoA बाट सक्सिनेट बन्छ, त्यतिखेर चाहिँ GTP भनेको हुन्छ. सक्सिनाइल बाट फ्युमेरेट भन्दाखेरि चाहिँ FADH2 भन्छ. फ्युमेरेट बाट म्यालेट बन्छ, म्यालेटले फेरि NADH दिन्छ भनेको NADH दिने तिनवटा रिएक्सन हो. एउटा आइसोसाइट्रेट टु अल्फा केटोग्लुटारेट, एउटा अल्फा केटोग्लुटारेट टु सक्सिनाइल CoA, एउटा चाहिँ फ्युमेरेटबाट अक्जालिस्टेट. अनि यो धेरै एकदम इम्पोर्टेन्ट छ. हामीलाई सक्सिनाइल CoA बाट सक्सिनेट भन्दाखेरि GTP भन्छ, सक्सिनेटबाट चाहिँ फ्युमेरेट भन्दाखेरि FADH2 भन्छ. Also Krebs cycle, pyruvate is converted to acetyl CoA, produces 1 NADH and 1 carbon dioxide. The TCA cycle produces the 3 NADH, 1 FADH2, 2 CO2, 1 GTP per acetyl CoA equals to 10 ATP, acetyl CoA, 2 into everything per glucose. TCA cycles reactions occurs in the mitochondria. Alpha ketoglutarate dehydrogenase complex requires the same cofactor as the pyruvate dehydrogenase complex. Okay, so next will be pyruvate metabolism. So glucose is converted to pyruvate ALT बाट चाहिँ एलानिन बाट केहिल साइकल भन्छ. पाइरुवेट चाहिँ साइटोसोल बाट माइटोकन्ड्रियामा चाहिँ पाइरुवेट पिसी युज गरेर अक्सलेटेट बनाउँछ हैन। अनि त्यसपछि पाइरुवेटले साइटोसलबाट माइटोकन्ड्रियामा गएपछि पिडिएचबाट चाहिँ पाइरुवेट डिहाइड्रोजिनेस कम्प्लेक्सबाट चाहिँ एसिटाइल कोए बनाउँछ। त्यतिखेर एनएडीएच एउटा फाल्ने भयो। अनि पाइरुवेटले चाहिँ फेरि ल्याक्टेटबाट कोरी साइकलबाट एलडीएच बनाउने भयो। त्यतिखेर चाहिँ एनएडीएच र एनएडी को रिएक्सन इन्भर्स हुन्छ। फंक्शन्स अफ डिफरेंट पाइरुवेट मेटाबोलिज्म pathways and their associated cofactors. Alanine aminotransferase B6. Alanine carries the amino group to the liver from the muscles. Pyruvate carboxylase B7 oxaloacetate can replace the TCA cycle or be used in gluconeogenesis. Pyruvate dehydrogenase B1, B2, B3, B5 and lipoic acid transition from the glycolysis to TCA cycle. Lactic acid dehydrogenase end of the aerobic glycolysis. Major pathway in RBC, WBC, kidney, medulla, lens, testes and cornea. Pyruvate dehydrogenase complex caused build up a pyruvate that has shunted to lactate by LDH and alanine ALT by X-linked. Finding includes neurogenic defect, lactic acidosis, increased serum albumin, alanine starting in infancy, increased intake of nitrogenic nutrients, high fat content or lysine and leucine. Okay, so the next are glycolysis regulation key enzymes. Net glycolysis glucose plus 2 pi plus 2 ADP plus 2 NAD plus gives pyruvate, 2 ATP, 2 NADH plus 2 H plus 2 CO2. Equation not balanced chemically and exact balance depends on ionization state of the reaction product. So glycolysis mein it requires ATP is glucose is converted to glucose 6 phosphate by hexokinase or glucokinase. Glucose 6 phosphate inhibits the hexokinase, whereas fructose 6 phosphate inhibits the glucokinase. And then fructose 6 phosphate is converted, rate limiting enzyme is phosphofructokinase 1, that is rate limiting, and it is converted to fructose 1 6 bisphosphate. This reaction is activated by AMP and fructose 2 6 bisphosphate positive. Okay, and ATP minus and citrate minus, these enzymes produce ATP are 1,3 BPG to 3 BPG. So phosphoglycerol pyruvate and phosphonol pyruvate to pyruvate by pyruvate kinase. These also enzymes like produces the ATP. So fructose 1 6 bisphosphate bisphosphate positive this end reaction, whereas ATP minus, alanine minus and glucagon minus this reaction. So regulation by fructose 2 6 bisphosphate. Fructose bisphosphate also known as fructose and phosphofructokinase are the same bifunctional enzyme whose function is reversed by phosphorylation by protein kinases. Okay, so here the reaction we have fructose, main reaction is fructose 6 phosphate बाट fructose 2 6 bisphosphate भन्ने हुन्छ. अनि यसमा चाहिँ के हुन्छ भने fructose bisphosphate बाट fructose 2 6 bisphosphate मा एउटा phosphate एड भएको छ. सो phosphofructokinase ले एउटा एनर्जी चाहिँ ट्रान्सफर गरिदियो phosphate हैन, and that is PFK2. okay, that is activated by insulin. okay, so अब fructose 2 6 bisphosphate activate insulin ले गरेपछि यसले PFK1 that is phosphofructokinase फेरि kinase 1 लाई यसले चाहिँ यो रिएक्सनलाई एक्टिभेट गर्छ. अब fructose 6 phosphate बाट चाहिँ fructose फेरि 1 6 phosphate बन्छ. यसले फेरि एउटा दुईटैतिर यसले के दिइराछ भने हाम्रो एउटा चाहिँ 2 6 बनाइरहेछ, एउटा 1 6 बाट चाहिँ 1 6 नै बनायो हैन, भनेपछि 2 6 र 1 6 यसको प्रोडक्ट रहेछ. अनि fructose 1 6 bisphosphate बाट ग्लाइकोलाइसिसमा इजिली गयो. तर अब फेड स्टेटमा इन्सुलिन माइनस छ भने चाहिँ फस्फोफ्रुक्टो के अरे फ्रुक्टोज बिसफस्फेटेज भन्ने फस्फेटेजले चाहिँ के गर्छ भन्दाखेरि हटाउँछ, रिमुभ्स द फस्फेटेज, रिमुभ्स द फस्फेट. सो फ्रुक्टोज 2 6 फस्फेटबाट चाहिँ फ्रुक्टोज 6 फस्फेट बन्छ. अनि त्यतिखेर चाहिँ फ्रुक्टोज बिसफस्फेटेज 1 हैन पनि एक्ट हुन्छ हैन, अनि त्यसले चाहिँ फेरि ग्लुकोनियोजेनेसिस गर्छ. सो फास्टिङमा चाहिँ के हुने भयो भन्दाखेरि फेड स्टेटमा के भने इन्क्रिज इन्सुलिन, डिक्रिज सीएमपी, डिक्रिज प्रोटिन काइनेज ए, डिक्रिज फस्फोफ्रुक्टो एज 2 चाहिँ डिक्रिज हुने भयो. इन्सुलिनले यतातिर फेड स्टेटमा के गर्ने भयो भने इन्सुलिन बढ्यो, सीएमपी घट्यो, प्रोटिनले पनि घटायो हैन, अनि डिक्रिज फस्फोफ्रुक्टोज A2 अनि PFK2 अनि यसले त्यता 20 फ्रुक्टोज इन्सुलिनले चाहिँ फ्रुक्टोज बिसफस्फेटेज 2 लाई चाहिँ इन्हिबिट गरिदिने भयो हैन, अनि इन्क्रिज दि PFK2. ओके, त्यतातिरबाट चाहिँ अहिलेसम्म चाहिँ क्याम्प घटाइदिन्छ, तर PFK2 मा चाहिँ ठ्याक्कै एक्टिभेट गरिदिन्छ कि, द्याट इज फस्फोफ्रुक्टोकाइनेज 2 मा मोर ग्लाइकोलाइसिस एन्ड लेस ग्लुकोनेसिस. तर फास्टिङ स्टेटमा के हुन्छ भने ग्लुकागनले चाहिँ सीएमपी बढाउँछ, इन्क्रिज प्रोटिन काइनेज ए, इन्क्रिज फस्फोफ्रुक्टोज phosphotase, okay, fructose bisphosphatase 2 लाई एक्टिभेट गरिदिन्छ अनि PFK 2 लाई चाहिँ लेस गरिदिन्छ अनि लेस ग्लाइकोलाइसिस एन्ड मोर gluconeogenesis हुन्छ. Okay, very easy. So now we have the pyruvate dehydrogenase complex, that is mitochondrial matrix, mitochondrial enzyme complex linking glycolysis and TCA, differentially required in fed, active or fasting inactive state. So reaction is pyruvate NAD plus CoA is converted to acetyl CoA CO2 and NADH. Contain 3 enzymes required 5 cofactors: thiamine pyrophosphate, lipoic acid, CO, that is B5 pantothenic acid, FAD B2 riboflavin, and NAD plus B3 niacin. So activated by increase NAD plus / NADH ratio or increase ADP or increase calcium. This complex is similar to the alpha ketoglutarate dehydrogenase complex. Same cofactor, similar substrate and action, which converts the alpha ketoglutarate to succinyl CoA. Arsenic inhibits the lipoic acid. Arsenic poison findings include image of vampire, pigmentary chain, skin cancer, vomiting, having diarrhea, running away from QT prolongation with garlic breath. Okay, so next we'll be talking about the glycolysis. Okay, so here the glycolysis will be glucose is converted to, for the glycolysis is occurs in the cytoplasm. Glucose is converted with the help of hexokinase or glucokinase in the glucose 6-phosphate and fructose 6-phosphate. Then fructose 6-phosphate is converted to fructose 1,6-bisphosphate by the enzyme phosphofructokinase 1. Then fructose 1,6-bisphosphate is converted to glyceraldehyde 3-phosphate by the this occurs by the enzyme aldose B. Okay, and glyceraldehyde 3-phosphate is converted to 1,3-bisphosphoglycerate, then 3-phosphoglycerate, and 2-phosphoglycerate, then phosphoenol pyruvate. Now phosphoenol pyruvate is converted to pyruvate by the enzyme called pyruvate kinase, and pyruvate is converted to acetyl CoA by the enzyme pyruvate dehydrogenase. So kinase then dehydrogenase. Okay, pyruvate भन्दा अगाडि चाहिँ काइनेज, पाइरुवेट भन्दा पछि चाहिँ हाम्रो डिहाइड्रोजिनेज है. त्यसपछि एसिटाइल कोएमा भन्यो. अब एसिटाइल कोएबाट चाहिँ डिफ्रेन्ट ठाउँमा रियाक्सन जान सक्छ. एसिटाइल कोएबाट चाहिँ साइट्रेट बन्छ हाम्रो टिसिएमा माइटोकन्ड्रियामा छिरेपछि हैन. त्यसपछि आइसोसाइट्रेट हुन्छ, अल्फा किटोग्लुटारेट, सक्सिनाइल कोए, सकिनेट, फ्युमेरेट, म्यालेट, अक्जेल एसिटेट. अब अक्जेल एसिटेटबाट चाहिँ के भनिन्छ, पाइरुवेटबाट डाइरेक्ट अक्जेल एसिटेट पनि बन्न सक्छ बाइ द एन्जाइम पाइरुवेट कार्बोक्सिलेज. ओके, अब अक्जेल एसिटेटबाट के हुन्छ भने फोस्फोइनोल पाइरुवेटमा पनि जान सक्छ बाइ द एन्जाइम फोस्फोइनोल पाइरुवेट carboxykinase. Okay, one is carboxylase, next is carboxykinase. Okay, so GTP is required this condition मा हो हैन. अनि फर्स्ट स्टेप ग्लुकोनेजेस भनेको पाइरुवेटबाट अक्जेल एसिटेटमा हो हैन. अनि अब एसिटाइल कोएबाट अरु के बन्न सक्छ भन्दाखेरि एसिटाइल कोएबाट चाहिँ मेलोनाइल कोए भएर फ्याटी एसिड भएर ट्राइग्लिसराइड भएर ग्लिसरोल भनेर DHAP भनेर DHAP बाट चाहिँ हाम्रो ग्लिसरल्डेहाइड 3-phosphate माथिको बन्न सक्छ अथवा DHAP बाट चाहिँ हाम्रो फ्रुक्टोज 1,6-bisphosphate पनि बन्न सक्छ. उताबाट फ्रुक्टोज मेटाबोलिजमबाट हेर्यौं भने फ्रुक्टोजको हाम्रो त्यही सेम हो. फ्रुक्टोजबाट फ्रुक्टोज 1-phosphate बाट DHAP बन्न सक्छ. त्यसैले नै यो चाहिँ हाम्रो अघि जस्तै ग्लिसरल्डेहाइड 3-phosphate र फ्रुक्टोज 1-phosphate पनि जान सक्छ अथवा फ्रुक्टोज 1-phosphate बाट ग्लिसरल्डेहाइड फस्फेट पनि बन्न सक्ने. अब एसिटाइल कोएबाट चाहिँ अर्को के जान्छ भने लिपिड मेटाबोलिजम एसिटाइल H2 एसिटाइल कोए देन फ्रम द HMG कोए देन कन्भर्टेड टु H2 एसिटेट एन्ड कन्भर्टेड टु बीटा हाइड्रोक्सी ब्युटारेट एन्ड देन HMG कोएमा चाहिँ मेबुलेनेट र कोलेस्ट्रोल पनि भन्ने भयो. अब ओट चेन फ्याटी एसिड आइसोल्युसन भ्यालिन मिथियोनिन एन्ड थ्रियोनिन भन्ने हुन्छ. द्याट इज कन्भर्टेड टु प्रोपेनाइल कोए एन्ड देन प्रोपेनाइल कोए इज कन्भर्टेड टु मिथाइल मेनाइल कोए एन्ड मिथाइल मेनाइल कोए इज कन्भर्टेड टु सक्सिनाइल कोए. अल्कोहलले NADH by NAD ratio बनाउँछ. Okay, so now we'll be converted to the succinate is converted to fumarate and then succinate is converted to fumarate, yes, and fumarate is also formed from, like when you talk about the urea cycle, NH3 plus CO2 forms the carbamyl phosphate, then converted to citrullin. Ornithine gets added up, okay, by ornithine transcarbamylase converted to citrullin, then aspartate arginosuccinate to arginine, and then the urea is produced. Okay. So when you talk about the glucose 6-phosphate is converted to 6-phosphogluconate, then to ribose 5-phosphate, then to the fructose 6-phosphate. Okay. So the fifth reaction, glucose 6-phosphate is converted to fructose phosphogluconate by the enzyme called G6PD. Okay, and from the ribose 5-phosphate is converted to fructose 6-phosphate by the enzyme transcriptase. This was HMP. Now galactose is converted to galactose 1-phosphate, then galactose 1-phosphate is converted to glucose 6-phosphate. Okay, and the glycogen is directly converted to glucose 1-phosphate, and UDP glucose 1-phosphate is converted to UDP glucose, then UDP to glycogen directly to glucose 1-phosphate. So now ATP production. Aerobic metabolism, one glucose molecule produces 32 net ATP by malate aspartate subtle, heart and liver, and 30 net ATP by glycerol 3-phosphate subtle, muscle. Anaerobic glycolysis produces 2 net ATP per glucose molecule. ATP hydrolysis can be coupled to energetically unfavorable reaction. Arsenic causes glycolysis to produce 0 net ATP. So activated carriers, ATP carrier inactivated is phosphoride group, NADH, NADPH, FADH2 gives electron in carrier inactivated form, CO and lipomide gives in acyl A group, biotin gives a carrier inactivated form by CO2, and tetrahydrofolate 1 carbon unit, and S-adenosine methionine SAM gives in CS3, and TTP gives carrier inactivated form in by aldehyde. So universal electron acceptor are nicotinamide, that is NAD plus, NADP plus from vitamin B3, and flavin nucleotide FAD from vitamin B2. NADH, NAD plus generally used in catabolic process to carry required equivalent as away as NADH, and NADPH is used in anabolic process, example steroid and fatty acid synthesis as a supply of reducing equivalent. NADPH is a product of the HMP shunt. NADPH is used in anabolic process, respiratory burst, cytochrome P450 system, and glutathione reductase. Phosphofructokinase versus glucokinase. Phosphorylation of the glucose to glucose 6-phosphate is catalyzed by glucokinase in the liver and the hexokinase in the other tissue. Glucokinase sequesters glucose in tissue, which is used even when glucose concentration are low. At high dose concentration, glucokinase helps to store glucose in liver. Glucokinase deficiency is the maturity onset diabetes of the young and gestational diabetes. Hexokinase property, location most tissues except liver and pancreatic beta cells. Km is low and increased affinity. Vmax is low, decreased capacity, induced by insulin, no. Feedback inhibition by glucose 6-phosphate. So Km and Vmax both are low in cases of hexokinase and both are high in cases of glucokinase. L for glucose, L L for liver and beta of pancreatic cells, and it is induced by insulin, yes, and fructose 6-phosphate is feedback inhibition of glucokinase. So now we'll be talking about the metabolism sites. The mitochondria, that is fatty acid oxidation, beta oxidation. Mitochondria में होने कुरा के fatty acid oxidation, beta oxidation, acetyl CoA production, TCA cycle, oxidative phosphorylation, and ketogenesis. Cytoplasm में होने चाहिँ glycolysis, HMP shunt, synthesis of cholesterol, protein ribosome RER, fatty acids and molecule, nucleotide, and both मा हुने भनेको हैन hemisynthesis, urea cycle, gluconeogenesis. Okay, so next we'll be talking about the enzyme terminologies. An enzyme name often described in a function. For example, glucokinase is an enzyme that catalyzes the phosphorylation of glucose using a molecule of ATP. Following are the common used enzyme descriptors. We have the kinase, catalyzed transfer of the phosphate group from high molecular ATP to a substrate, phosphofructokinase. Phosphorylase adds inorganic phosphate, one substrate without using ATP. Glycogen phosphorylase. Phosphatase removes phosphate from substrate, fructose 1,6-bisphosphatase 1. Dehydrogenase catalyzes the oxidative and reductive reaction like pyruvate dehydrogenase. Hydroxylase adds hydroxyl group on substrate, tyrosine kinase. Carboxylase transfers the CO2 group with the help of biotin, pyruvate carboxylase. Mutase is relocate a functional group within a molecule, that vitamin B12 dependent methyl vanillyl CoA mutase. And we have the synthase and synthetase, that is join two molecules together using a source of energy, ATP, acetyl CoA, and nucleotide sugar. Rate determining enzyme for metabolic process. Glycolysis means phosphofructokinase 1. So regulator is AMP plus, fructose 2,6-bisphosphate plus, ATP minus, and citrate minus. We have gluconeogenesis, fructose 1,6-bisphosphatase 1. That is regulator is AMP minus, fructose 2,6-bisphosphate minus. TCA cycle isocitrate dehydrogenase. ADP regulator ADP plus ATP minus, NADH minus. Gluconeogenesis is glycogenesis is glycogen synthase, glucose 6-phosphate plus, insulin plus, cortisol plus, epinephrine minus, glucagon minus. Now we have glycogenolysis, that is glycogen phosphorylase, epinephrine plus, glucagon plus, AMP plus, glucose 6-phosphate minus, insulin minus, ATP minus. We have HMP shunt, glucose 6-phosphate dehydrogenase, NAD P plus positive, NADPH minus. De novo pyrimidine synthesis, carbamyl phosphate synthesis to ATP plus, PRPP plus, UTP minus. De novo purine synthesis, glutamine phosphorylamine phosphorylase aminotransferase. Okay, so PRPP aminotransferase, that is AMP minus, ionosine monophosphate IMP minus, and GMP minus. Urea cycle, carbamyl phosphate synthesis 1, N-acetyl glutamate positive. Fatty acid synthesis, acetyl CoA carboxylase, insulin positive, citrate positive, glucagon minus, palmitoid CoA minus. Then we have fatty acid oxidation, carnitine acyl transferase 1, that is malonyl CoA minus, ketogenesis, HMB CoA synthase, and cholesterol synthesis, HMG CoA reductase. CoA reductase means insulin plus, thyroxine plus, estrogen plus, glucagon minus, cholesterol minus. Next we have the ethanol metabolism. Ethanol converted to acetaldehyde by alcohol dehydrogenase. Formation inhibits this system. NAD plus converted to NADH. Acetyl CoA बाट चाहिँ एसिटेट बन्दाखेरि चाहिँ हाम्रो एसिटाल्डिहाइड डिहाइड्रोजिनेज ले चाहिँ हाम्रो यो रिएक्सनलाई गभर्न गर्छ, डाइसल्फिरामले इन्हिबिट गर्छ. ग्लुकोनेओजेनेसिस वाट ह्यापन इन इन्क्रिज NADH / NAD plus ratio inhibits TC cycle, increase acetyl CoA used in ketogenesis, lipogenesis, hepatic steatosis. Female are more susceptible than male to effect of alcohol due to decreased activity of gastric alcohol dehydrogenase, decreased body size, decreased percentage of water in the body weight. NAD plus is the limiting enzyme. Alcohol dehydrogenase operates by zero order kinetics. Ethanol metabolism increase NADH by NAD plus ratio in liver, causing lactic acidosis, increased pyruvate conversion to lactate, fasting hypoglycemia, decreased gluconeogenesis due to increased conversion of OAA to malate, ketogenesis, diversion of acetyl CoA into ketogenesis rather than TCA cycle, hepatosteatosis, increased conversion of DHAP to glycerol 3-phosphate, and acetyl CoA diverges into the fatty acid synthesis which combines with glycerol 3-phosphate to synthesis triglycerides. You have the fomepizole blocks alcohol dehydrogenase, preferred antibiotic for overdose of methanol or ethanol glycol. Alcohol dehydrogenase has a high affinity for ethanol than for methanol or ethylene glycol. Ethanol can be used as a competitive inhibitor of alcohol dehydrogenase to treat methanol or ethylene glycol poisoning. Disulfiram blocks acetyl dehydrogenase, increase acetaldehyde, increase hangover symptoms, and discourage drinkings. Okay, then we have protein energy malnutrition. Protein malnutrition resulting in the skin disease, edema due to decreased plasma oncotic pressure due to low serum albumin, liver malfunction, fatty changes due to the decreased apolipoprotein synthesis and deposition. Clinical picture is for children with swollen abdomen. Kwashiorkor results from protein deficient like malnutrition, edema, anemia, liver fats, and skin conditions like hyperkeratosis, dyspigmentation. Marasmus is malnutrition not causing edema. Diet is deficient in calorie but not nutrition, so entirely are absent. Marasmus results in muscle wasting. We have the zinc, mineral essential for the activity of 100+ enzyme imported in the formation of zinc finger, transcriptional factor moiety. Okay, if deficiency lead to delayed wound healing, suppressed immunity, male hypogonadism, decreased hair, axilla facial paving, dysgeusia, anosmia, associated with the acrodermatitis entropathica, defect in intestinal zinc absorption, may dispose to alcohol cirrhosis. Vitamin K includes phytomenadione, phyloquinone, phytonadione, and menaquinone. So function is activated by epoxide reductase to the reduced form, which is cofactor for the gamma carboxylation of glutamic acid on various protein required for blood clotting synthesized by international flora, necessary for maturation of clotting factors 2, 7, 9, 10, protein C and S. Warfarin inhibits vitamin K dependent synthesis of this factor and protein. Deficiency leads to neonatal hemorrhage, increased PT, increased FTT, but normal bleeding time. Neonates have destroyed intestine and unable to synthesize vitamin K. Can occur after prolonged use of broad-spectrum antibiotic, not in breast milk. Breastfed infants don't know about the vitamin D and K. Neonates are given vitamin K injection at birth to prevent the hemorrhagic disease of newborn. Next we have vitamin E, includes the tocopherol, tocotrienol, antioxidant, protects the RBC and the membrane from free radical. Deficiencies of vitamin E can lead to hemolytic anemia, acanthocytosis, muscle weakness, demyelination of posterior column, decreased proprioception and vibration sensation, decreased spinothalamic tract. So vitamin E can lead to neurological presentation may appear similar to vitamin B12 deficiency but without megaloblastic anemia, hypersegmented neutrophils, or increased methylmalonic acid. Excessive can lead to risk of enterocolititis in infants, and high dose supplementation may alter the metabolism of vitamin K, enhance anticoagulation in terms of warfarin. So vitamin D, D3 is cholecalciferol. From excess of skin stratum basically to some ingestion of the fish milk plant. D2 is ego-calciferol from ingestion from plant, fungi and yeast. Both converts to 25 OS D3 storage form in liver to the active form 125 OS to D3 calcitriol in kidney. So vitamin D is increased intestinal absorption of calcium and phosphate, increased bone mineralization at low level, increased bone mineralization at higher level. So regulation of vitamin D is by increased PTH, decreased calcium, decreased phosphate, and increased 125 OS2 D3 production. 125 OS2 D3 feedback inhibition is on production. Increased PTH, increased calcium reabsorption, and decreased phosphate reabsorption in the kidney. So vitamin D deficiency indicates in children deformities such as genu varum, bole, osteomalacia in adults, bone pain and muscle weakness, hypocalcemia, tetany, caused by malabsorption, decreased sun exposure, poor diet, chronic kidney disease, advanced liver disease. Given oral vitamin D to breast infants, darker skin and premature precoce to deficiency, excessive hypercalcemia, hypercalciuria, loss of appetite, stupor, seen in granulomatosis diseases, increased activation of vitamin D by thyroid macrophage. So next is vitamin C, also known as ascorbic acid. Antioxidant also facilitates iron absorption by reducing it to Fe2 plus state, necessary for hydroxylation of protein and lysine collagen synthesis, necessary for dopamine beta hydroxylase, converts dopamine to norepinephrine. Next we have the vitamin C, ascorbic, swollen gum, easy bruising, fatigue, hemorrhage, anemia, poor wound healing, perifollicular and subperiosteal hemorrhage, cuts through hair, weakened immune response. Deficiency can be precipitated by T-adipose type. Vitamin C deficiency called ascorbic due to collagen hydroxylation defect found in the fructose and vegetable, known as ascorbic acid. Anti-ciliary treatment for methylmalonine by reducing Fe plus 3 plus to Fe2 plus. Deficiency can lead to swollen gum, easy bruising, fatigue, hemorrhagosis, anemia, poor wound healing, perifollicular and subperiosteal hemorrhage, cuts through hair, weakened immune response. So vitamin C excess can lead to nausea, vomiting, diarrhea, fatigue, calcium oxalate nephrotic acid. Can increase the iron toxicity in predisposed individuals by increasing the vitamin iron absorption, can worsen hemochromatosis or transfusion related iron overload. So vitamin B12 is also known as cobalamin, is a cofactor for methionine synthase, transfer CS3 as methylcobalamin and methylconyl-CoA mutase, important for DNA synthesis. Next we have the vitamin B12 macrocytic megaloblastic anemia, hypersegmented PMH, paresthesia, and subacute combined degeneration of the posterior column, lateral spinothalamic tract, and spinocerebellar tract due to the abnormal migration, associated with the increased serum homocysteine and methylmalonic acid, associated with the secondary folate deficiency, prolonged deficiency, irreversible lung damage. So found in the animal product synthesized by the only by microorganism, very large deserved food and stored primarily in the liver. Deficiency caused by malabsorption, sprue, enteritis, diaphragm, botham natum, chorhydria, bacterial overgrowth, alcohol overuse, lack of intrinsic factor, pernicious anemia, gastric bypass surgery, absence of terminal illness, surgical dissection, often with Crohn's disease. Drug includes metformin or insufficient vitamin intake by agents. Benign supplement can mask the hematological symptoms of B12 but not the neurological symptoms. Next is vitamin B9, also called the folate, converted to THF, a coenzyme for one carbon transfer methylation reaction, important for synthesis of nitrogenous base in DNA and RNA, found in the green leafy vegetables, produced by gut flora, absorbed in jejunum, folate from foliage, severe reserve food stored in primarily in the liver. So macrocytosis deficiency lead to macrocytosis, megaloblastic anemia, hypersegmented polynucleosis, glossitis, non-neurological symptoms, as opposed to vitamin B12 deficiency, increased homocysteine, normal methylmalonic acid seen in chronic alcohol overuse and in pregnancy. Deficiency can be caused by severe drugs like phenytoin, sulfonamide, methotrexate, supplementation folic acid at least 1 month prior to conception, and early pregnancy to decrease germ level to defect, given vitamin B9 for B9 and for the pregnancy. We have the vitamin B7, also called the biotin, cofactor for carboxylation reaction, which add one carbon compound. Pyruvate carboxylase gluconeogenesis is pyruvate 3 carbon compound is converted to alkyl 4 carbon compound. Acetyl-CoA carboxylase fatty acid synthesis, acetyl-CoA 2 carbon compound is converted to malonyl-CoA 3 carbon compound, and propenyl-CoA carboxylase fatty acid oxidation, propenyl-CoA 3 carbon compound is converted to methyl-malonyl-CoA 4 carbon compound. So vitamin B7 relatively rare, dermatitis, enteritis, alopecia, caused by the long-term antibiotic use or excessive ingestion of raw food. Okay. So the next is vitamin B5, also known as pantothenic acid B5. Okay, and is component of the coenzyme A, a cofactor of acyl transferase and fatty acid synthase. Vitamin B5 dermatitis, enteritis, alopecia, adenolism, similarly to burning sensation of feet, burning feet syndrome, dystoparesthesia and dysesthesia. Vitamin B6 also called pyridoxine, convert to pyridoxal phosphate, a cofactor used in transamination, ALT, AST, decarboxylation reaction, glycogen phosphatase, synthesis of glutathione, cystathionine, heme, niacin, histamine, neurotransmitter include serotonin, epinephrine, norepinephrine, dopamine, and GABA. Deficiency lead to convulsion, hyperreactivity, peripheral neuropathy. Deficient includes isoniazid and oral contraceptive, sideroblastic element due to impaired hemoglobin synthesis and iron. Next, we have the vitamin B3, niacin, and nicotinic acid, constitute of NADP. NADP plus used in the redox reaction as a cofactor by dehydrogenase derived from tryptophan. Synthesis requires B2 and B6 used to treat dyslipidemia, decrease biliary layer, increase HDL. Okay, niacin, NAD derived from niacin, B3 equals to 3 ATP. Glossitis, severe deficiency leads to glossitis. Severe deficiency of B3 leads to pellagra, which can cause Hartmann disease, malignant Hartmann disease, autosomal recessive deficiency of neutral amino acid, example tryptophan, transported in the proximal renal tubules and on intracytes. Neutral amino aciduria, decreased absorption from blood, decreased tryptophan from conversion to niacin, pellagra-like symptoms, treated with high protein diet and nicotinic acid, deficiency of vitamin B3, pellagra, less B3. So next, the deficiencies can lead to malignant carcinoid syndrome, increased tryptophan metabolism, increased serotonin synthesis, and isoniazid decrease in vitamin B6, symptoms of B3 deficiency, pellagra, diarrhea, dementia must also hallucination, dermatitis, CCCO, brown stripe, broad ballot rash, castless neck, hyperpigmentation of something. So excessive can lead to flushing, induced prostaglandin, not histamine, can avoid by taking aspirin with niacin. Okay, so hyperglycemia and hyperuricemia, excessive vitamin D3 leads to podagra, and that is gout, overdose, excessive B3. Okay, now we have the B2, also known as the riboflavin, component of flavin, FAD, and FN used as a cofactor in redox reaction, the succinate dehydrogenase reaction, the TCA cycle. FAD and FN are derived from the riboflavin. Vitamin B2, cheilosis, inflammation of the lip, scaling and fissure of the corner of the mouth, may enter corneal vascularization. So next is the vitamin B1, also known as thiamine. In thiamine pyrophosphate, a cofactor for several dehydrogenase enzyme reaction, branch chain keto acid dehydrogenase, alpha glucosidase dehydrogenase, pyruvate dehydrogenase, and transketolase from HMP salt, pyruvate dehydrogenase from link glycolysis to TCA, alpha glucosidase TCA cycle, branch and emission. These all are functions for B1. The deficiency lead to impaired glucose breakdown, ATP depletion worsened by glucose infusion, highly anaerobic tissue, brain and heart. Okay, and affected first in patients with the chronic alcohol overuse or malnutrition, give thiamine before dextrose to decrease the risk of precipitated encephalopathy. Diagnosed made by increased RBC transketolase activity followed by B1 administration. So next we have warning encephalopathy, that is causing acute reversal life-threatening neurological conditions, symptoms like confusion, ophthalmoplegia, nystagmus, and ataxia. Korsakoff syndrome, amnestic disorder due to the brain chronic alcohol overuse present with confabulation, personality change, memory loss. We have Wernicke-Korsakoff syndrome, damage to the medial dorsal nucleus of the thalamus, mammillary body, present in combination of Wernicke-encephalopathy or Korsakoff syndrome. Have dry beriberi, polyneuropathy, systemical muscle wasting. Okay, and wet beriberi, high cardiac output failure, dilated cardiomyopathy, and edema. So next we have the vitamin A, that is the retinoic acid, antioxidant, constitute the visual pigments retinol, essential for normal differentiation of epithelial cells into specialized cells called pancreatic mucosecreting cells, prevent squamous metaplasia. So retinol is a vitamin A and used for tropical wrinkles and acne, found in the liver and leafy vegetables. Supplementation is in vitamin A deficient patient may improve outcome. Use oral isotretinoin to treat severe acne, or transretinoic acid to treat acute promyelocytic leukemia. So deficiency of vitamin A, night blindness, nyctalopia, dry skin, xerocyst cutis, dry skin, xerophthalmia, corneal squamous metaplasia, bitter spot keratitis, debris, palmy appearance in conjunctiva, corneal degeneration, keratomalacia, and immunosuppression. Excessive vitamin A leads to acute toxicity, nausea, vomiting, increased ICP, vertigo, blurred vision, and the vitamin A chronic toxicity leads to alopecia, dry skin, hepatic toxicity, and enlarged arthritis, idiopathic intracranial tension, teratogenic cleft palate, cardiac abnormality. Therefore, a negative pregnancy test and two forms of contraception are required before isotretinoin vitamin A derived is prescribed. Okay, so the next is the essential fatty acid, polysaturated fatty acid that cannot be synthesized in the body. It must be provided in a diet, not seed, plants, oil seeds. Linoleic acid, omega 6 metabolite to arachidonic acid, which serves as a precursor to leukotrienes and prostaglandins. Linoleic acid, omega 3 is a metabolite, hence cardioprotective and anti-hyperlipidemic effect. So vitamins A, D, E, K absorption depends on the ileum and pancreas. Toxicity more common than water-soluble vitamins because of fat-soluble vitamins accumulate in fat. Malabsorption syndrome with steatorrhea, cystic fibrosis, and celiac disease or mineral oil intake can cause folate, fat soluble vitamin deficiencies. And B1 thiamine B2 riboflavin, FAD and FMN. B3 is niacin NAD+. 5 is pantothenic acid CoA. 6 is pyridoxine PLP. B7 is biotin. B9 is folate. B12 is copalamin. C is ascorbic acid. Washed out easily from the What all vitamins also easily from the body except B12 and B9. B2 is stored in liver for 3 to 4 years. B9 is stored in liver for 3 to 4 months. B complex deficiency often results in dermatitis, blood and diarrhea, and can be coenzyme ascorbic acid or precursor to coenzyme FAD and FM. So now we'll be talking about the genetic disorders of chromosome. So third common BHL adrenal cell carcinoma. 4 is ADPKD, achondroplasia, Huntington's disease. 5 is Creutzfeldt, familial adrenal polycystis. 6 is hemochromatosis. 7 Williams syndrome, cystic fibrosis. 9 fatty ataxia and tuberous sclerosis. 11 is Williams syndrome, beta glycogenic defect, sickle cell anemia, beta thalassemia, main one. 13 is Patau, Wilson's, retinoblastoma, BRCA2. 15 is Prader-Willi, Angelman and Marfan. 16 is ADPKD, alpha globulin chain defect, alpha thalassemia, tuberous sclerosis, TS2. 17 neurofibromatosis 1, BRCA1, TP53, Livraume. 18 is Edward. 21 is Downs. 22 is neurofibromatosis 2, disorders is 22. X is fragile X, X-linked glomerulotomy, and infantile XXY. So Robertson translocation, chromosomal translocation that commonly involves the chromosome pair of 21, 22, 13, 14, and 15. One of the commonly type of translocation occurs with the long arm from 2 concentric chromosome with centromere near the end, fuse at the centromere, and 2 short arms are lost. Balanced translocation, no gain or loss significant genetic matter, normally do not cause abnormal phenotype. On balanced translocation, missing or extra gene can result in miscarriage, stillbirth, chromosome imbalance, Down syndrome, and Patau. We have to chart the cry of the baby, congenital deletion of short arm of chromosome 5, 46, XX or XY, 5P. Finding microcephaly, moderate to severe intellectual disability, high pitched cry, epicanthal fold, and cardiac abnormality like PSD. Williams syndrome, congenital microdeletion of the long arm of chromosome 7, deletion is an elastin gene. Distinct life in face, intellectual disability, hypercalcemia, well-developed verbal skins, extremely friendliness with the strangers, cardiovascular problem, suprapulmonary aortic stenosis, and renal artery stenosis. So next we'll be talking about the autosomal trisomies. Like autosomal monosomies are incompatible with life and are due to high chance of expression of the recessive trait for the chromosome. Down syndrome 21, intellectual disability, flat flash, prominent epicanthal fold, single palmar crease, curved finger, gap between the first and second, duodenal ataxia, Sprung disease, congenital heart disease, broad spot whitish spot on the periphery of the iris, has to be the early onset Alzheimer's disease, chromosome 21 for mild precursor for increased risk of AML, ALL. And in the case due to meiotic non-gene junction, most commonly due to increased meiosis with advanced age material from 1:1500 in the female, less than 20 to 1:25 in female, less greater than 45. 4% cases due to unbalanced Robertson translocation, most typically between the chromosome 14 and 21. Only 1% of the case due to post-translation mitotic error. So drinking age 21, most common viable chromosome disorder, most common cause of genetic intellectual disability. First trimester ultrasound commonly shows increased knuckle translucency and hypoplastic nasal bone. Markers for Down syndrome, increase SCG, increase inhibin. 5A of Down syndrome is advances, atresia, atrioventricular septal defect, Alzheimer's disease, AML and ALL. Edward syndrome, trisomy 18, finding Prince Edward, prominent occiput, rocker bottom feet, fracture disability, non-disjunction, lens feet with overlapping fingers, low set ears, micrognathia, congenital heart disease, omphalocele, myelomeningocele, death usually occurs by election at 18. So second most common Edward trisomy is resulting in live birth. Most common is Downs, Edward syndrome, every prenatal screening marker decreases. Patau 13, finding severe intellectual disability, rocker bottom feet, microphthalmia, microcephaly, cleft lip and palate, whole prosencephaly, polydactyly, cutis congenital heart pump disease, polycystic kidney disease, omphalocele, there is the cause by one, defect infusion of precordial measure of midline data. So in trisomy first trimester, what you can learn is so only in 21 beta SCG first trimester only trisomy 21 beta SCG is increased. Rest all the factors like in 21, 18 and 13 Papa and beta SCG all are decreased except in 21 first trimester beta SCG is increased. When you talk about the second trimester, so second trimester the things that are when you talk about in the 21, the beta SCG and inhibin are increased in the second trimester, whereas decrease in estradiol and AFP. When we talk about the Edward, all the parameters are always decreased in 18 and 13. But in cases of 13, second trimester, no parameter is seen. Okay. So the non-dysfunction occurs at the meiosis 2. Okay, and the outcomes are trisomy, monosomy, 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 trisomy. When the non-dysfunction in meiosis 1 it occurs, then the results are trisomy and monosomy. Okay, when the non-dysfunction meiosis 2 occurs, normal, monosomy, and trisomy. So when we talk about the repeat expansion, so the genetic anticipation, disease severity increase and age of onset decrease in successive generation. So Huntington's, that is case CAG, or is autosomal dominant, and cowded has cowded has decreased ACH and GABA. Next is myotonic dystrophy, that is CTG. Okay, that is autosomal dominant. So C for cataract, T for trough, that is early blindness in male, and G for gonad atrophy in male, reduced fertility in female. We have fragile X, that is CGG, that is X-linked dominant. Okay, चौधरी fragile X नामी चाहिँ X तपाईले X-linked भयो हैन, त्यसमा चाहिँ अनि CGG हुन्छ gene protruding giant gonans. Okay, fragile X has giant gonans and protruding gene. सबै कुरा fragile X को बाहिर निस्किन्छ, X भित्रबाट उसको बाहिर निस्किन्छ हैन. And Friedreich's ataxia is GAA, that is ataxic gait, that is autosomal recessive. Next we have the Rett syndrome, sporadic disorder, also seen almost exclusively in female, affected male die in utero or shortly after birth. Most common cases are caused by de novo mutation MECP2 on chromosome X. Symptoms of Rett syndrome usually appears between 1 to 4 and are characterized by regression in motor, verbal, cognitive ability, ataxia, seizure, growth deceleration, stereotyped hand wrinkling. Fragile X is X linked dominant inheritance, trinucleotide repeat in FMR1, hypermethylation of the cytosine residue and decrease expression. Okay, and that is most commonly inherited due to intellectual disability. Down syndrome is a most common genetic cause, but most cases are occurring sporadically. Fragile X, there is trinucleotide repeat of CGG occurs during oogenesis. Mutation 50 to 200 repeats. Tremor, ataxia, primary ovarian insufficiency, full mutation greater than 200 repeats. Postural post pivotal macroorganism in large testes for long face with jaw, large everted ear, autism, mitral prolapse, hypermobility joint. Self-mutilation is common and can be confused with listening hand syndrome. Okay, so we talked about the Rett syndrome, that is sporadically seen in almost in females. Affected males die in utero and shortly after birth. Most cases causes de novo mutation MECP2 on chromosome X. Symptoms of Rett syndrome usually appears between the age 1 and 4 and characterized by regression in motor, verbal, cognitive ability, ataxia, seizure, growth deceleration, stereotyped hand wrinkling. So next we will be talking about the autosomal dystrophies, like Duchenne muscular dystrophy, X-linked recessive disorder, typically frameshift deletion on nonsense mutation, truncated or absent dystrophin gene, progressive myofiber damage, weakness begins in pelvic girdle muscle, progressive suprarenal, pseudo-lipodystrophy of the calf muscle due to fibrofatty replacement of the muscle, waddling gait, onset before 5 years of age. Dilated cardiomyopathy is a common cause of death. Governor Chinese patients usually uses upper extremity to help stand up. Classically seen in Duchenne muscular dystrophy, also seen in the muscular dystrophy and inflammatory myopathies like polymyositis. Muscular dystrophin gene is the largest protein coding human gene. Increase chance of spontaneous mutation. Dystrophin helps in anchor muscle fibers, primarily in skeleton and cardiac muscle. It connects the intracellular cytoskeleton actin to the transmembrane protein alpha and beta dystroglycan, which are connected to the extracellular matrix. Loss of dystrophin, myonecrosis, increased CK or loss is increased. Genetic testing confirms the diagnosis. Beckers is X-linked recessive disorder. So Goward Chinese patient usually uses upper extremity to help stand up. Classically seen in Duchenne muscular dystrophy, also seen in many muscular dystrophies and inflammatory myopathies like polymyositis. Okay, Becker muscular dystrophy is X-linked recessive disorder, typically seen non-frameshift deletion dystrophin gene, partially function instead of truncated. Let's see whether Becker is better. Onset is adolescent or early childhood. Deletion can cause both the muscular and Becker muscular dystrophy. 2/3 of the cases have large deletion spanning one or more exons. Myotonic dystrophy is autosomal between 20 to 30 years. CTG, trying to repeat expansion in TMPK gene, abnormal expansion of myotonic protein kinase, myotonia, difficult releasing hand from handshake, muscle wasting. Okay, so cataract, testicular atrophy, frontal balding and arrhythmia, cataract, coffee, and gonadal atrophy. So next we will be talking about the cystic fibrosis. And cystic fibrosis, which is autosomal recessive CFTR gene on chromosome 7, commonly or deletion of PHE 508, common lethal genetic disease in patient with European accent. So cystic fibrosis is CFTR encodes ATP gated chlorine channel that secretes the chlorine in the lungs and GI tract and absorbs chlorine in the sweat gland. PHE 508 deletion, misfolded protein, but protein trafficking and protein retention in area, protein absent from cell membrane, decreased chlorine in water secretion, increase intracellular chlorine results in compensatory increase in reabsorption by epithelial sodium channels, increased water reabsorption, abnormally thick mucus secreted into the lungs and GI tract, increased sodium absorption also cause more negative transepithelial potential difference. Cystic fibrosis increased chlorine concentration in pilocarpine-induced sweat is diagnostic, can present with the concentration alkalosis, hypokalemia. ECF effects analogous to a patient taking loop diuretics because ECF, water and sodium losses by sweating and concomitant renal potassium sodium wasting, increased immunogenic tryptosinogen, newborn screening due to clogging of pancreatic duct. We have complications like recurrent pulmonary infection, SRS, infancy and early childhood, student and adult, allergic bronchopulmonary aspergillosis, chronic bronchitis and bronchitis, reticulonodular pattern chest X-ray, ossification of a sinus, nasal polyp, lip clogging. Okay, progressive to endocrine dysfunction. Okay, pancreatic insufficiency, malabsorption, steatoria, and fat-soluble vitamins. ADK progress to endocrine dysfunction, CFTR-related diabetes, biliary cirrhosis, liver disease, meconium-milious in newborns, infertility in male. Okay, absence of vas distension, spermatogenesis may be unaffected, and solving fertility in male, amenorrhea, abnormal thick mucus. Okay, treatment is multifactorial, chest physiology, albuterol, oralized door NAS alpha DNase, and inhaled hypertonic saline facilitates mucus clearance. Azithromycin used as an inflammatory agent, buprenorphine slow throat disease progression, pancreatic enzyme replacement therapy, pancreatic for pancreatic insufficiency, combination Duma-Caftor or Teza-Caftor. Each corrects misfolded protein and improves their transport to cell surface, while Eva-Captor opens chlorine channel and improves chloride transport. So normally what happens is CFTR gets the chlorine inside and sodium inside with inert channel, and but in cystic fibrosis what happens is chlorine cannot get inside the cell. Chlorine cannot come to the sweat duct, okay, and sodium is also inside only, so no sodium, no chlorine, so the mucus becomes thick. So in air, this was in the sweat gland. Sweat gland मा के हुन्छ भने CFTR चाहिँ जनरली सेल भित्र आउँछ हैन, सोडियम पनि भित्र सेल भित्र आउँछ नर्मली, तर सिस्टिक फाइब्रोसिसमा के भइदिन्छ भने तिनीहरू सेल भित्र आउन सक्दैन र क्लोरिन र सोडियम चाहिँ बाहिरै रहन्छ हैन, त्यसले गर्दाखेरि चाहिँ स्वीट क्लोरिन देख्छ। अब एयरवेमा के हुन्छ भने हाम्रो क्लोरिन चाहिँ बाहिर नर्मली जान्छ हैन, अनि हाम्रो वाटर र सोडियम चाहिँ भित्र आउनुपर्छ हैन नर्मल केसमा, तर हाम्रो के अरे म्युटेटेड सिस्टिक फाइब्रोसिसमा के भइदिन्छ भने क्लोरिन चाहिँ बाहिर जान पाउँदैन हैन, अनि के अरे हाम्रो सोडियम र वाटर चाहिँ पनि भित्रै बसिदिन्छ कि, भनेको स्वेट क्लोराइडमा क्लोरिन र सोडियम बाहिरै हुने भयो, तर सिस्टिक फाइब्रोसिसमा क्लोरिन सोडियम वाटर तीनटै चाहिँ सेलभित्रै हुने भयो, त्यसले गर्दाखेरि डिहाइड्रेटेड म्युकस हुन्छ हैन, थिक म्युकस हुन्छ है। यति याद राख्ने, स्वेट क्लोराइडमा क्लोरिन सोडियम बाहिर, एयरवेमा चाहिँ क्लोरिन र सोडियम सेलभित्र है। त्यो पछि अब हाम्रो चाहिँ अटोजोमल रिसेसिभ डिजिजहरू के हो भन्दाखेरि इज प्लिज क्यान स्टुडेन्ट हु स्कोर हाई ग्रेड्स टेल मी द फिचर्स अफ द किडनी डिसअर्डर। सो अटोजोमल रिसेसिभमा ओकुलोक्युटेनियस अल्बिनिजम, फिनाइलकेटोनुरिया, सिस्टिक फाइब्रोसिस, सिकल सेल एनिमिया, विल्सन्स डिजिज, स्पिङ्गोमाइलिडेज, एक्सेप्ट फ्याबी डिजिज, क्रोमेटोसिस, ग्लाइकोजन स्टोरेज डिजिज, थ्यालेसेमिया, म्युकोपोलिसेग्राइड एक्सेप्ट हन्टर, फ्राइड्रिक्स एटेक्सिया एन्ड कार्टिजिनल सिन्ड्रोम। अटोजोमल डोमिनेन्ट डिजिजमा अकन्डोप्लाजिया, अटोजोमल डोमिनेन्ट पोलिसिस्टिक किडनी डिजिज, फ्यामिलियल आइडोनस पोलिपोसिस, फ्यामिलियल hypercholesteremia, hereditary hemorrhagic telangiectasia, Oslo-Rendo syndrome, hereditary spherocytosis, Huntington's disease, okay, and Lee-Fromme syndrome, Marfan syndrome, multiple angular neoplasia, myotonic muscular dystrophy, neurofibromatosis 1, von Renklinghausen disease, neurofibromatosis type 2, TS, and von Hippel-Lindau. So all are autosomal dominant. So when we talk about the autosomal dominant mode of inheritance, often due to defect in the structural gene, main generation, both male and female are affected, often pleiotropic, multiple apparently unrelated effect, and variable expression, difference between individuals, family history crucial to diagnose with one effect, heterozygous parents, on average 1.5 of children affected. When we talk about the autosomal dominant, all the generations are affected, okay. So capital and small a, So when like um, both is have a disease thing, okay, and one so here both male and females are affected, okay. So 50% chance. So autosomal recessive when we talked about, so autosomal recessive ma ke huncha bhane carrier huncha हैन, with two carrier heterozygous parents on average 1/4 of the children will be affected, one half the children will be carrier, and 1/4 of the children will neither be affected nor carrier, often due to enzyme deficiency usually seen in one generation, commonly more severe than dominant disorder. Patients often present in childhood. Increased risk in consanguineous families. Unaffected individuals with affected siblings has 2/3 probability of being a carrier. Unaffected individual with affected sibling. Unaffected individual with affected sibling has 2/3 probability of being a carrier. Unaffected individual from affected sibling has 2/3 probability of being a carrier. Next, we have X-linked recessive. Son of heterozygous mother have 50% chance of being affected. No male-to-male transmission in X-linked recessive. Skip generations. Okay, so carrier हुन्छ र मेल टु मेल ट्रान्समिसन हुँदैन. ओके, सो फिमेलले नै ट्रान्सफर गरिरहेको छ हैन, त्यति कुरा बुझ्नु पर्यो. Commonly more severe in male, affected usually most be homozygous to be affected. So X-linked dominant one transmitted through both parents. Mother transmitted 50% of daughter and sons. Father transmitted to all daughters but no sons. So Fragile X syndrome, Alport syndrome, hypophosphatemia rickets, also called X-linked hypophosphatemia, phosphate wasting at the proximal tuberous rickets-like presentation. Next we have mitochondrial inheritance, transmitted only through the mother. All offspring of the affected female may show the sign of disease. Whether expression in the population or even within a family due to heteroplasmy. Next, we have mitochondrial myopathies, rare disease, often presents with myopathy, lactic acidosis, and CNS disease. Melas syndrome, mitochondrial encephalopathy, lactic acidosis, stroke-like syndrome, secondary to failure in oxidative phosphorylation. Muscle biopsy often shows ragged red fibers due to accumulation of disease and mitochondria in soft sarcolemma of the muscle fiber. We have hereditary optic neuropathy, cell death in optic nerve neurons, some acute bilateral vision loss in teenage and young adults, 90% visually permanent, also leads to neurological dysfunction, cardiac and multi defects. So next we have the Prader-Willi syndrome, that is imprint disorder of imprinting. Imprinting one form is silenced by methylation, and another copy is expressed as a parent of original defect. Prader-Willi maternally derived genes are silenced. Disease occurs when the parental allele is deleted or mutated. There is hyperphagia, obesity, intellectual disability, hypogonadism, hypotonia, chromosome fitting of parental origin. 25 cases are due to maternal uniparental disomy. 25% cases due to maternal uniparental disomy and Prader-Willi, obesity, overeating, and parental allele deletion. POP. So Prader-Willi, obesity, overeating, and parental allele deleted. In Angelman, derived from UBE3A is silenced. This occurs when the maternal gene are deleted or mutated. So seizures, ataxia, okay, is the cell for Angel Island. So a cell or seizure, ataxia, intellectual disability, and appropriate laughter. UBE3A or maternal copy of chromosome 13. 5% of cases are due to maternal uniparental disomy. Mama's maternal allele deleted, Angelman syndrome, mood, ataxia, and seizure. So next we have the genetic conditions. Okay, so we'll be talking about the. So now we have the genetic terms like codominance. Both alleles contribute to the phenotype of the heterozygous. Blood group A, B, alpha-hydroxylation deficiency, HLA group. Variable expresses. Patients with the same genotype have variable phenotype. So two parents with the neurofibromatosis type 1 may have varying disease severity. So incomplete penetration, not all individuals with the mutant phenotype shows the mutated phenotype. Percentage penetration is probability of inheriting the genotype. Okay. Percentage penetrance into probability of inheriting the genotype equals to risk expressing the phenotype. BRCA1 gene mutation do not always result in breast and ovarian cancer. Okay. Pleiotrophy is the PKU. So one gene contributes to multiple phenotypic effects. Untreated phenylketonuria manifest with the skin lesion, intellectual disability, and muscular dystrophy. And this is increased severity of early onset disease in a succeeding generation, triangular midlife disease. Law of heterozygosity. If parents inherited or develop a mutation in a tumor suppressor gene, the wild type allele must be deleted or mutated before cancer develops. This is not true for retinoblastoma and pleural diabetes, Lynch syndrome, HNPCC, Liframi syndrome. Next, we have the dominant negative mutation exerts a dominant effect of heterozygous produced a non-functional altered protein that also prevent the normal gene product from functioning. A single mutated p53 tumor suppressor gene results in protein that is able to bind DNA and block the non-mutated p53 from binding to the promoter. Next, we have lineage disequilibrium, tendency for certain only at second link loci to occur together more or less often than expected by chance, measured in population, not in family, and often results in different population. Next, we have mosaicism, that is the presence of genetically distinct line in the same individual. Somatic mosaicism, mutation occurs from a mitotic error after fertilization and propagates through multiple tissue or organ. Gonadal mosaicism, mutation only in egg or sperm cells. If parents and relatives do not have the disease, suspect gonadal mosaicism. So we have McQueen Albright syndrome due to GS protein activating mutation present with neonatal calcium. It ranked as polystotic fibrous dysplasia. Bone is replaced by collagen and fibroblast, and at least endocrinopathies, precocious puberty. Lethal if mutation occurs before fertilization, affecting all cell lines but survival in patients with mosaicism. We have loss of heterozygosity, that is, mutation at different loci can produce a similar phenotype, that is, albinism, retinitis pigmentosa, and familial hypercholesteremia. Allelic heterozygosity, beta thalassemia, different mutation in the same locus produces the same phenotype. We have heteroplasmy, presence of both normal and mutated mtDNA results in the variant expressivity multiple inherited disease. DNA passed from mother to all children. We have uniparental disomy. Offspring receive 2 copies of chromosome from one parent and no copies from the other parent. Heteroidiosomy, I is heterozygous, indicates a meiosis 1, and isodiosomy, homozygous, indicates a meiosis 2, error of post-zygotic chromosome, duplication 1 or more pair of chromosome, and loss of the other original pair. So uniparental is euploid, correct number of chromosome. Most occurs uniparental disomy, normal phenotype, constitutes isodiosomy in an individual manifesting a recessive disorder when one parent is carrying, example, Prader-Willi and Alzheimer's syndrome. Hardy vegan bird population genetic, PNQ represents the frequencies of alleles, NA respectively. P square is frequency of homozygous for allele, Q square is the frequency of homozygosity for allele, A2PQ is frequency of heterozygosity. If autosomal recessive, thus the sum of the frequency of this genotype is P square plus 2PQ plus Q square is to 1. Frequency of an X-linked recessive male is Q and female is Q square. Hardy-Fock law assumption includes no mutation occurs at the locus, natural selection is not occurring, competitive randomity, no net migration, large population. If a population is Hardy, then the value of PNQ remains constant for generation to generation. So next we'll be talking about